everyone, in this episode I interview Mr Bilal Alkhaffaf about obesity and bariatrics. If you enjoy these podcasts, please subscribe. I'm Dr Gail Busby and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Mr Bilal Alkhaffaf about obesity and bariatric surgery. Bilal is an upper gastrointestinal surgeon with a special interest in minimal access surgery and bariatric surgery. He's widely published and well respected. I'm really glad to have him on the show and I'm looking forward to learning a lot from him today. Bilal, welcome. Thank you so much for agreeing to appear on the show.
Thank you, Gail. I'm looking forward to our discussion today.
So, Bilal, I find it fascinating to learn why accomplished colleagues like yourself chose to work in the area of medicine. So can you enlighten us as to why you chose to work in the field of weight loss surgery?
So thank you. It's a very interesting question. Many of those who know me will know that several members of my family are medics. My father is a surgeon, and that, without a shadow of a doubt, has played a large part in why I've chosen this field of medicine and surgery in particular. But I think most of us who go into the field of surgery could potentially have chosen one of several different fields or specialties to go into. And I think it all boils down to who your mentors are, who are the people that have really influenced you, who are the people that have really inspired you and impressed you. And that, without a shadow of a doubt, it has gone down to the upper GI surgeons that I've worked with during my training. The other thing with upper GI surgery, it allows us to treat a wide variety of different conditions. So we're going to be talking about obesity and weight loss today. But in other aspects of my job, I treat cancer, stomach cancer, esophageal cancer. I also treat benign disease, reflux, achalasia, those types of conditions as well. So the field is broad enough that it allows me to satisfy my needs and my requirements as a surgeon, but is also specialized enough that it allows me to focus on cutting edge technologies and cutting edge research as well. And that is a kind of a summation of why I've chosen upper GI surgery, but why I love what I do as well.
Thank you for that. Bilal, as you know, this podcast is aimed at educating patients. And as a result, we try to avoid using medical terminology as far as possible in order that the podcast remains as accessible to everyone as possible. Okay, so let's start with the basics. Can you define obesity for us? And are there varying levels?
At the most basic levels, obesity can be described or defined as the excessive accumulation of fat, which poses a threat or a risk to health. And both of these aspects of the definitions are really important. So whilst excessive fat accumulation can be a problem in and of itself, it's really the risk to health, and not just physical health, but mental health, overall well-being, quality of life, that's just as important. So whilst as medical professionals, we may focus on somebody's particular weight, we also need to think about the impacts of the weight or some of the negative side effects that the weight has. And that's also why when we come to talk about the treatments and look at the outcomes and results of weight loss surgery and weight loss procedures, we also have to bear in mind that we need to understand the positive impacts in terms of the positive impacts on health. I've been following your podcast now for the last few weeks, and I've been looking at many of the different topics that you've covered so far and that you plan to cover as well. So I was very interested because most, if not nearly all of the topics that you've discussed so far have an association with obesity and weight gain. And I'm going to read a list of those out if you don't mind. So endometrial cancer, polycystic ovary syndrome and infertility, breast cancer, type 2 diabetes. You've talked to a surgeon about hip replacement and joint problems. The menopause is associated with obesity, prostate cancer as well. And then you're going to be talking to people about inflammatory bowel disease, colorectal cancer, prolapse and urinary incontinence, eczema and other skin conditions. All of these conditions are directly associated and made worse by obesity. We understand that there are currently over 220 comorbidities or medical conditions and counting that are directly affected by or made worse by obesity. And that's why the definition very much focuses not just on the actual weight, but also the impact. You've asked me as well about whether there are different grades or levels. As medical professionals, we use a term called body mass index, which is shortened to BMI. Lots of people have heard about this. And what BMI does is it takes into account a person's weight in relation to their height. And when we reach a number or a value of 30, that's generally counted as the first stages of obesity. The higher the levels, the more obese or the higher levels of obesity a person has. Now, BMI really is a general guide. It's not perfect. It was developed many, many years ago, and some of the definitions that we used to look at what a normal BMI is and what obesity is based on a historical group of patients, probably about 30 years ago from Northern Europe. And so really doesn't reflect the ethnic diversity or ethnic differences in BMI. So on a day-to-day basis, we use it because it's really, really easy to calculate body mass index. It's a guide. And of course, the higher the number, the worse the obesity is, and the worse we are likely to see the degree of medical conditions affected by weight as well. So whilst we will look at BMI, we also again have to look at the medical conditions that are associated with weight. And when you ask me about the different levels, I also have to look at not only the absolute weight that a person has, but also the degree of complexity of their medical conditions. We look at, for example, diabetes, how many medications a person is on for diabetic medications, how long they've had diabetes for. So it's a simple question, but it's a complicated answer, and there's not a really black and white way of looking at it.
Well, thank you. That was a brilliant answer, actually. Thank you. And yeah, I didn't realize that you are the common thread for my podcast thus far. It is really, really important subject, and that's why I'm so grateful for you for educating us today. So being familiar with the podcast, you will know that I always ask about risk factors, because I think it's really important that if someone even doesn't have a condition yet, maybe they are at risk for the condition, and there are perhaps lifestyle modifications that they can employ to reduce their levels of risk. Are there any identifiable risk factors for obesity? Does it start in childhood, as is commonly thought, and can it be prevented or modified?
Okay, so that's another excellent question, and really we could probably spend 2 hours just talking about the risk factors associated with obesity. I think I'd like to start really by talking about some facts and figures. We know that in the UK, 2/3 of adults are either overweight or have obesity. We also know that 1 in 4 children are either overweight or have obesity. So this problem is not going away anytime soon. By the fact that children are suffering with obesity, we know that the problem, at the very least, for some people, starts from a very, very young age. When I speak to patients about their weight, and when patients come to see me about treatment, one of the very first questions I ask them is about the history of their weight problems. The vast majority of people who come to speak to me have suffered with weight from a very, very young age, either in childhood or since puberty or since the late teens. So it absolutely is a problem which starts at a very, very young age. Commonly, when we look at the media, when we look at the social media and the mainstream media, we can see some quite negative connotations with obesity, and a lot of stigmatization of people who suffered or suffer with obesity. There's often a misconception that this problem is solely down to not moving enough and eating too much. And without a shadow of a doubt, nobody who comes to see me wishes for their condition to be blamed on anybody else, or doesn't wish to take responsibility or have some accountability to being in the position that they're in. But we have to understand that this problem is a lot more complex than simply eating too much and not moving enough. I was reading quite an interesting article which used the analogy of a classroom, that if we have a classroom of 20 people, 20 children, and one of two of them fail the exam, then we should probably look towards the child as the issue, or their parents, or their support network. But if you have a classroom full of people failing the examination, then we need to be taking a real look at ourselves and looking outside of the classroom and looking at the teacher and the wider education system. And this is a very, very good analogy for obesity. There are a whole host of contributory factors and modifiable risk factors which are ingrained within our society as a whole. And I'd love to talk about those. Let's talk about, for example, activity levels. Without a shadow of a doubt, as a society, we move far less than we used to before. We drive everywhere. We sit at our desks. You and I are sitting at our desk right now talking to one another. And, the vast majority of people now move far less. Some people are affected by reduced levels of activity, not because of choice. Some people have problems because of immobility, medical conditions that affect their ability to move. Some people have been in road traffic accidents or have had serious injuries or back injuries, which have reduced their ability to move. And so a reduced physical activity is not necessarily always a choice. Eating behaviors, absolutely. I think generally speaking, the majority of people that come to see me have eating behaviors that they're not happy with. But that comes down to education. We talked about the fact that young people now are suffering with weight and obesity. 1 in 4 children are overweight or obese. That means there's a problem with education. How do we educate people to eat properly at the right times, eating the right things? From a biological perspective, we know genetic does absolutely play a part in whether somebody has a propensity or a higher risk of developing obesity. Certain medications and certain hormonal conditions such as polycystic ovary syndrome, which we've talked about, underactive thyroid, that can affect somebody's ability to burn the calories that they're consuming. We know that from a wider perspective, pervasive advertising can certainly be a big player in why societies have an increased prevalence or an increased incidence of obesity. There's a reason why people go to university to learn marketing and advertising, because it's so influential. And that's why when we look at social media platforms, a lot of these high turnover companies spend a lot of money investing in advertising and media because it works. We know that, for example, people who struggle with their mental health have a much higher incidence of developing obesity. So there's lots of different contributory factors which influence the body's ability to burn off the calories that it consumes. It's not simply a case of, well, you need to move more and eat less. That may be part of the solution and part of the longer term solution, but that's certainly not the whole picture.
Okay. And my next question was going to be, why is it important? But in your opening, you've made it clear that obesity can affect so many organ systems. It can be very, very important in the genesis or the cause of various cancers. Would you like to tell us, in your view, why obesity and tackling obesity is important on either an individual or even a societal level?
So we've touched upon the fact that obesity is associated with medical conditions in every single organ system. We've talked about cancer. We've talked about heart disease. We've talked about diabetes. We know that it can affect fertility. It can affect mobility. It can affect, our ability to sleep. It's associated with obstructive sleep apnea. There are so many medical conditions that affect an individual's health and quality of life, and ultimately reduce a person's life expectancy. So if we want to live long and happy and healthy lives, I've got to be careful with the word happy here, but if at the very least, if we want to live a long and healthy life, we absolutely need to be tackling obesity on an individual basis. On a societal basis, the burden that obesity has on the wider society is hugely significant. We live in a society with a public health system in the UK. We know that billions are spent on treating conditions associated with obesity, we've talked about type 2 diabetes, chronic conditions that are there for life require millions and actually billions of pounds spent from a pharmaceutical perspective, from a surgical perspective. If you go through every single organ system, there's an operation or a medication that is being dispensed or undertaken in order to treat a problem which is certainly either being caused by or made worse by obesity. So as a society, we talk about the immense financial pressures that we're under as a society, and yet we face these problems, and these are issues that unfortunately are difficult to tackle easily and will require long-term visions and strategies to help alleviate these problems. When we talk about weight loss surgery or weight loss treatment, we're talking about, to a degree, treating people who have already gone beyond a point whereby they find it difficult to lose the amount of weight. But we also have to tackle the source of the problem, which is obesity within childhood, and therefore we need strategies to reduce the incidence of that as well.
Okay. And can you give us an idea of when it starts to become a problem? When does the level of risk sort of ramp up? Is there an idea that people can have in their minds? Because I think that's useful as well.
Yeah, that's also a very, very good question. And our understanding of the answer to your very, very important question has changed significantly over the last 10 or 15 years. Traditionally, we've set the mark as a BMI of 30, whereby your risk of developing certain metabolic conditions such as diabetes significantly increases. I talked to you about what that was based on. And that was based on a cohort of white Caucasian Northern Europeans some 30 years ago. Things have moved on significantly. We know that the risk of developing type 2 diabetes, let's use that as an example, starts at a much lower BMI depending on your ethnicity. So South Asians, their risk of developing type 2 diabetes is closer to 27. Black and Middle Eastern, again, the risk of developing type 2 diabetes is less than their Caucasian counterparts. So it very much depends on a number of factors, including their ethnicity. So what I would generally begin to advise people, certainly in the UK, is when your body mass index is getting near 30, you need to be concerned because there are some real health implications. And if you are of a different ethnic background, you need to be mindful of the fact that those risks increase at a much lower body mass index.
That's fascinating information, actually. So is there a point of no return, weight-wise, after which surgery is the only feasible option in your experience?
I think we have to be very careful when we talk about surgery as a kind of a silver bullet. I think we have to be mindful of the fact that obesity as a condition, our understanding of it has changed significantly, and we know that our understanding is such that obesity is seen as a chronic relapsing condition. So surgery in and of itself can't cure obesity, but what it can do is help people manage obesity and tackle obesity in the longer term. With respect to your question about is there a point of no return, that's very difficult to answer. We know that if we take a step back and look at the data and what research we have, we know that when a person suffers with obesity, when their body mass index goes above 30, we know that 90% of people are unable to significantly reduce and importantly sustain weight loss through diet and exercise alone. Now, there is no cutoff point. I can't tell you that if you get to a BMI of 30 or 35 or 40, that is a point of no return. Everybody is different. We talked about what the contributory factors were, and there being a complex formula that for everybody is slightly unique. But without a shadow of a doubt, the heavier you get, the higher your body mass index gets, the more difficult it then becomes for people to make the necessary modifications that they need to lose the weight that they need to lose. Lots of people may be able to lose some weight, but then to sustain the lifestyle choices or to modify those contributory factors to a degree in a sustained manner whereby they can lose a lot more weight becomes very, very difficult. And so I guess my answer in short to you is that there's no specific cutoff point, but the heavier you become, the more difficult it then is to lose the weight that you need to lose. We talk about a body mass index of 25 being somebody's upper limit of an ideal weight. Again, that's not a hard and fast rule. I certainly don't use that measurement or that criteria for my patients when I speak to them. But it's a target, it's a guide. And if you can imagine, if somebody who should be no more than 75 kilos is coming to speak to me or one of my colleagues and they weigh 150 kilos, losing 75 kilos is a major, major task. And that's where treatments such as bariatric surgery can come into play and become very useful.
And it's just entered my mind, talking about obesity and surgery. Yes, you're talking about bariatric surgery, but the other big influence of obesity is in someone who needs surgery for something else. And obesity significantly increases surgical and anesthetic risks as well. And maybe that's not, immediately obvious to people that, the same operation, if you are very obese, is more difficult to perform and the risks are higher.
You're absolutely right. And one of the reasons why people will come and see us is because they need access to further surgery. One of the topical conditions that you've certainly covered is cancer surgery. Endometrial cancer surgery, for example. We have got a good relationship with Professor Crosby and yourselves and the wider team of gynecologists across the Northwest region, because we know that for patients who require further surgery, a hysterectomy, or maybe patients need a knee replacement because their weight has affected their joint so significantly, they will come to see us because they need to lose a significant amount of weight to then be able to go and have surgery more safely. In some scenarios, actually, for example, knee or hip replacement, the reduction in weight achieved through bariatric surgery can negate or remove the necessity of them needing to undergo that further surgery, which is a bit ironic. But we're here to help people, and that's a message that I want to put out today, is that there is help available. There is a powerful tool available for people who struggle with their weight. And as I said to you before, this is a lifelong struggle that affects every aspect of a person's being. Patients who struggle with obesity, they wake up thinking about their weight, they go to sleep thinking about their weight. Their weight affects every aspect of their daily life, from mobility to their mental health to their physical health. And there are treatments available that can help alleviate some of those problems.
Okay. And moving back now to bariatric surgery, under what circumstances should it be considered? And how would you counsel patients? Because we've just said that performing any surgery on a patient who has obesity is risky. So there must be risks associated with the bariatric surgery itself, which we'll come on to. But before that, when a patient comes and inquires after bariatric surgery, what helps in your decision-making process in offering them surgery, and how do you counsel them?
Okay. So another good question. So we'll talk about complications separately and the risks associated with bariatric surgery separately.
Yes.
So let's start by talking about the eligibility criteria for bariatric surgery. The guidance that we have is set by NICE, which is the national health body within the UK. So currently, if you have a body mass index of 40 or more without any weight-related medical conditions, you are eligible for bariatric surgery. If you have a body mass index of 35 with a weight-related medical condition, then you are eligible for bariatric surgery. As we talked about before, if the NICE guidelines also take into account somebody's ethnic origins. So if you're South Asian, you can take 2.5 BMI points off that as well. If you have type 2 diabetes, which is recently diagnosed, and what I mean by recently diagnosed, I mean within the last 5 to 10 years, then again, the BMI criteria is lower still. But these are changing sands, and these are actually arbitrary figures. There's no real reason why those criteria have been set. And I don't really want to get into the politics of these criteria, but what we do know is that recently the International Federation for Society for Obesity and also the American Metabolic and Bariatric Surgical Society have released a consensus statement which advises that anybody with a BMI of 35 without weight-related medical conditions should be offered bariatric surgery, and that association with weight-related medical conditions, the BMI eligibility criteria should be reduced to 30. I think what's really important for people and patients to understand, and people who are thinking about bariatric surgery, is it's not just about what box you fit into, which criteria you might sit in. When I speak to you in a clinic, when I speak to a patient in a clinic, I will go through a person's weight loss history. It may be that patients have yo-yoed throughout their life. I need to take into account their medical background and to what degree that weight has impacted on their health, not just physical, but also mental health and well-being. And that really helps me formulate a picture about that individual. And weight loss surgery really needs to be considered on an individual basis. We need to take everybody individually and not just as a box. Well, you fit in there, or you're not eligible. And that's really a more realistic approach that myself and my colleagues take.
Okay. And in terms of the technical detail of the operations themselves, I believe there's more than one procedure. What exactly does bariatric surgery entail?
So when I talk to my patients in clinic, I will not only talk to them about the surgical options, but I'll also have to talk to them about the non-surgical options. And when we speak about the different procedures and treatments that are available for obesity, we really need to give the patients the choice of a whole range of different treatments, even though they may be treatments that I don't offer. So when we talk about an informed consent process, we need to give patients all the options, including the first option that I always give them is do nothing at all. That's the option that's going to avoid the risk of a procedure. The downside to that is that there are risks of doing nothing, which we've talked about already today. If we take the ladder of the least invasive procedure all the way up to the most invasive procedures, we can start off with medical weight management. So medical weight management involves a multidisciplinary team, which means a number of people, number of specialist health professionals working together offering medical treatments for people who have obesity. And that might involve lifestyle modification, psychology input, that may be offering them certain medications. And there are a number of new injectable medications that have really come out on the market over the last 1 or 2 years that have changed the landscape for a lot of people. So we talk about that. We also talk about non-surgical endoscopic treatments, such as the gastric balloon. And that is a silicone device which we fill with fluid. We place it using a camera or gastroscope into the stomach. It makes people feel full, and then we remove that balloon approximately 6 or 12 months later. On average, people will lose anywhere in the region of about 1.5 to 2 stone. Some people have more success than others. And the interesting thing with the gastric balloon is that now there's a type of balloon that comes in a pill form attached to a small tube, which you can swallow in the outpatient clinic. We can fill with fluid, and then we can have the patient x-rayed, and that balloon dissolves by about 4 months. The results from that type of balloon is a little less impressive compared to the traditional gastric balloon, but nonetheless, it is an option. We have seen different endoscopic treatments. Endoscopy means using a camera down the throat under sedation, whereby we place stitches internally to make the stomach smaller, and that's called an endoscopic sleeve gastrectomy, different to the surgical sleeve gastrectomy, which we'll get onto in a second. The endoscopic sleeve gastrectomy is very much in its embryonic stages. It's very much in its early stages. It's not widely adopted. And so we don't really have the long-term outcomes or results at hand to tell us how successful it is. But that's something that's certainly on the horizon and looks like it will increase in availability in the UK for sure. When we move on to the surgical options available to patients, the least invasive surgical option would be the gastric band. Now, the gastric band, also known as the adjustable gastric band or the lap band, really came into popularity about 10 or 15 years ago, I would say. That was the peak of its popularity, when the options really were very limited. You had the option of the band or the gastric bypass, which we'll talk about in a second. The gastric band is the least invasive procedure that we offer. It involves placing an implantable device around the top of the stomach. This device is made of silicone. It's attached to a tube, which then sits attached to a port deep to the skin, which we can inject with fluid. And that fluid increases the tightness or the restriction at the top of the stomach, making people feel full. Now, whilst it's the least invasive option available to us, in the longer term, we know that the band is probably the option which is associated with the most problems. And as a consequence, we're finding that we're taking out a lot more bands than we put in nowadays. We then move on to the sleeve gastrectomy. The sleeve gastrectomy, by far and away, is the most popular option anywhere on the face of the planet currently. It probably accounts for at least 2/3, if not more, of all bariatric surgical operations, and for good reason too. The sleeve gastrectomy is permanent. It involves cutting away a portion of your stomach, probably anywhere from about 2/3 to 3/4 of the stomach. Importantly, the part of the stomach that we cut away is the part that produces the hunger hormone, or the hormone responsible for your hunger, which we call ghrelin. So the operation works not just by restricting what you can eat and drink, because we're making the stomach smaller, but we also see now the beginnings of hormonal changes that really affect your appetite. We also know that there are really powerful changes to the hormones within the body and the chemicals within the body that govern and control the pathways between the intestines or the gut and the brain, which also promotes weight loss. The gastric sleeve, as I said to you, is very popular because it results in a significant amount of weight loss. On average, people are losing more than 70 to 80% of the extra weight that they're carrying. And that, for a lot of people, is extremely powerful. And that's weight loss that they've never been able to achieve before. Then we move over to the gastric bypass, and the gastric bypass is the one that we've been doing for the longest. It's the procedure, whilst it's the most invasive, it's the one that we've been doing for the last 60 years. So it's what we would term the gold standard bariatric operation. It's the one against which we measure all newcomers or all new types of procedures or bariatric surgeries. It involves making a small pouch from the top of the stomach, no bigger than the size of your thumb, and then we cut the intestine and we join it to that stomach pouch. So food no longer then travels down to the bottom part of the stomach and the first part of the intestine. Again, our understanding of how these procedures work has changed immensely over the last 10 years or so. Initially, we thought that this procedure worked by simply restricting what you can eat and drink, and then by malabsorption as well, by stopping your body absorbing calories. But actually, whilst that might be partly true, our understanding is that the hormonal changes that occur probably are what drive the significant weight loss. Importantly, with procedures such as the sleeve and the bypass, the hormonal changes are so massive and so immediate, then lots of people who are on diabetic medications can come off their medications immediately after surgery. Lots of patients can come off their medications for high blood pressure immediately after surgery. So we know that the power of this surgery lies not only in restricting what you can eat and drink, but also by changing the hormonal balances that govern your blood pressure, that govern diabetes control and sugar control in the body.
Wow, thank you for such a comprehensive answer and for such really clear explanations of the various options. So I had no idea that there were so many options available, and I guess it comes back to individualized care. Do you want a temporary or a permanent? How much weight do you wish to lose, etc.? And that all comes down to counseling and patient choice.
Absolutely. And you've talked about tailored and specific treatment plans for individualized care.
Yeah.
And that's what we do as bariatric surgeons. It's not a one size fits all. And when patients come to see a surgeon, they really need to consider whether or not that surgeon offers all the different treatments, or is it just somebody who offers one type of treatment. Okay. There's an adage that I like to use, which is, if your only tool is a hammer, then every problem is a nail. And not everybody's problem is a nail. Everybody has a different problem or a different set of circumstances that may require a different approach. And just for an example, I'll give you an example. We know that type 2 diabetes probably responds best to a Roux-en-Y or a full gastric bypass. People who have severe reflux shouldn't go for a sleeve gastrectomy necessarily, because we know that the sleeve gastrectomy can be associated with higher incidence of reflux after surgery. We know that people who have had lots of abdominal surgery, well, they may not be suitable to have a bypass operation because of the adhesions and the need for us to use the bowel. So it's really, really important that patients understand that when they come to see us, they may have an idea in their mind what they wish to pursue from research or from what their maybe friends, family, or people on social media that they've seen have undergone or have pursued. But we have to reassess the situation when you come to see us. Yeah,
absolutely. And is there anything that patients can do to prepare for bariatric surgery?
Preparing for bariatric surgery is something that we talk about comprehensively when you come to see us in the clinic. And this is probably a good time to introduce the concept of a multidisciplinary team to the discussion. When you come to speak to us about bariatric surgery, you might come and see the surgeon in the clinic, but you must understand that a surgeon and the surgery is only one part of the entire treatment package that you'll be offered. When we talk about bariatric surgery, we also have to understand that in order for it to be successful in the longer term, we need to deal with those underlying issues that may have contributed to weight gain in the first place. And so preparing for bariatric surgery, absolutely, we need to look very, very carefully at those contributory factors and what can be done before surgery to minimize the risk of regaining weight or you not achieving the results that you want to achieve in the longer term. When I work very closely within a large team of dietitians, bariatric nurses, psychotherapists, even our administrative team and our practice team are well versed in bariatric surgery and the different treatments, and that cannot be underestimated. When you have had your surgery, then really the majority of the work and the majority of the focus is mainly on the aftercare team and the wider multidisciplinary team. You'll, of course, be followed up by myself as a surgeon, but generally speaking, once people get out of the first 3 months, from their recovery and they're back eating normal foods, then the focus is very much on diet, nutrition, physical activity, and addressing the underlying issues that may have contributed to for weight gain in the first place. I think now is probably a good time to talk about health tourism as well, because one thing that we are aware of is that bariatric surgery may be significantly cheaper abroad, and we have lots of people who might be going abroad to have surgery as a consequence, but what they don't get is the aftercare. What they don't get is a multidisciplinary team approach. And as a consequence, time and time again, we're seeing people who are maybe going abroad for cheaper surgery, but don't appreciate that surgery is just one aspect of the treatment that they have to that they have to get or that they have to consider. But the aftercare, the support, the education, quite often people can struggle psychologically post-operatively because let's use the example of food as somebody who has an emotional eating disorder. Their main fallback or their crutch is eating. So when they have their crutch or their dependency disappears or goes away, that can be psychologically traumatizing for the person and can result in all kinds of problems. So it's not just a case of having the surgery and all your problems will be fixed. This is absolutely not the message that I want to give out today. This has to be a multidisciplinary team approach. So preparing for surgery very much involves us addressing those issues before you come anywhere near an operating table or an operating theatre, and that will give you the best chance in the longer term. In the run-up to surgery, there is something called a liver-reducing diet or a liver-shrinking diet that you'll need to undertake or perform. The liver-reducing diet does exactly what it says on the tin. It reduces the size of the liver, and that's important because the liver sits directly on top of your stomach. And for us to be able to safely undertake surgery on the stomach, we need to be able to carefully move the liver out of the way and retract it to one side so that we can get to the stomach and do what we need to do. So that will be one specific example of how you may need to prepare for surgery. Quite often I get asked, do I need to lose a specific amount of weight in the run-up to surgery? There is no need to lose a specific amount of weight, but what you should know is the more weight you can lose in the run-up to surgery, the easier the surgery is for the surgeon, and the easier an operation it is for me. Well, my life's made a lot easier, but importantly, you're less likely to have complications and problems post-operatively.
Okay, so that takes us nicely to my next question. So when we offer any type of surgery, we always weigh the benefits versus the risks. So I'm sure you have detailed conversations with your patients about the risks surrounding bariatric surgery. Would you like to enlighten us as to some of these risks, the ones that you think are most important to mention today?
The first thing I want to say is that bariatric surgery is extremely safe. It's as safe as an example, having your gallbladder removed. That's the one that we tend to use as a comparison. Lots of people have had their gallbladders out or know somebody who's had their gallbladder out. The surgery is keyhole surgery and recovery is quick. Most people can go home the following day after their operation. and most people are back to work by 2 weeks. So I don't want people thinking that, yes, this is invasive surgery, but neither do I want for people to have disproportionate levels of fear about the safety of this operation. Having said that, what I don't do is, and what none of my colleagues will do, is be complacent about the fact that this is still surgery. Surgery still has the small risks of complications. Now, each of the procedures has complications specific to it. And let's give you an example. The gastric balloon, for example, that can be poorly tolerated and may require removing early. And as a consequence, people will not be able to lose the weight that they would have hoped to have lost had the balloon had stayed in longer. And the common causes for not being able to keep the balloon down is nausea and vomiting. Moving on to the gastric band, we know that the gastric band can be associated with short and longer term problems. The common things that we see are infection of the band. We can see gastric slippage, which means that the stomach slips up through the band. Sometimes people call that as band slippage. We know that the band can break or fail, or very rarely can even erode into the stomach, which means that it needs to come out. With respect to the sleeve gastrectomy, we've briefly talked about the risk, the longer term, of heartburn and reflux. The other thing that we like to talk about is the risk of the staples not healing, and that's what we term a leak. And a leak will require further treatment and surgery. When it comes to the gastric bypass, similarly, there are risks of the joins not healing properly. You can also have risks of bleeding from any of the keyhole or laparoscopic surgery. We talk at great length to the patients or people who are considering bariatric surgery about these risks. But again, I want to stress to you the importance that bariatric surgery is extremely safe. But not only that, but we take significant steps to reduce the risks of problems arising in the first place. That comes through working closely in a highly experienced team of people who are used to operating on people who struggle with their weight. That includes operating with anaesthetists that are used to putting people to sleep with a high BMI, and that's really, really important. And not only that, but managing people who have comorbidities or significant medical problems that need managing around the time of surgery as well.
Okay, and as you said before, these complications, they must be discussed thoroughly, because absolutely that's the right thing to do. And we don't do it to scare patients, because even when I'm counselling patients about surgery, I think, gosh, this sounds like this happens every day. It hardly ever happens. But that doesn't remove the fact that they all need to be discussed. So as you say, it shouldn't be a barrier to accessing the care you need. Okay, so you mentioned about, you said in a line, when patients are back to eating normal food, which I thought was an interesting statement. Are there any lifestyle changes or dietary changes that are required after surgery?
Yeah, so that really refers to a patient's recovery post-operatively. What we often like to do is gradually reintroduce normal foods post-operatively to allow the body to heal, to allow any swelling or edema or fluid around the operation site to settle, and for the joints to really weld together shut. If you are eating normal foods straight away after surgery, then there's a higher risk of leakage, there's a higher risk of food getting stuck. We are changing the shape of the stomach from something which is maybe the size of a small melon to, in the sleeve, something the size of a banana, or in the bypass, as I've mentioned, something the size of your thumb. So restrictions different, and people need to understand that this is about wholesale lifestyle changes, including those related to eating and eating behaviors. In the first 2 weeks post-operatively, we'll encourage people to stay on fluids and fluids only. Then they'll move on to a pureed diet, then for 2 weeks, and then another 2 weeks of a sloppy type of diet. And then by 6 weeks, generally, most people are back to eating normal foods. And that's what's key here. One of the things that we've learned as health professionals is that dieting doesn't work because it's not sustainable. And food is strongly linked to how we feel, how we socialize. And if you want a long-term sustainable option for you, it needs to be long-term and it needs to be sustainable. And what I mean by sustainable, it needs to be palatable. And so if you're going to have somebody who's just on a liquid diet for the rest of their life, that is utter misery. Nobody wants that. And so when we're talking about the long term, we have to reassure patients that you will be eating normal foods. However, the amount will be a lot smaller, and we will need to focus more carefully on the makeup of that food. There's a strong focus on protein intake. There's a strong focus on fluid intake. And that in and of itself is going to help you lose weight and maintain weight loss in the longer term. But we also need to bear in mind that because the stomach is a lot smaller following the sleeve and the bypass, it simply will not be possible for you to gain all the necessary vitamins and nutrients, certainly in the first 6 to 12 months post-operatively, which is why the current guidance is from our national society is that patients are placed on long-term nutritional supplementation. And that's something that we will go through in a lot more detail, not just myself, but the wider team that you meet if you want to go down this road.
Okay. So no dramatic lifestyle changes. So you can still eat and enjoy the food you love, but just in smaller amounts, and you will require supplementation. Have I got that right?
So there will be dramatic changes post-operatively. And the dramatic changes come from the fact that you have lost so much weight, particularly in that first 12 months. Probably the biggest changes that we see are the changes to people's levels of physical activity. Just by losing so much weight, people feel like they have more energy, they're able to exercise or undertake physical activity a lot more easily. And as a consequence, therefore, go from a negative cycle of not being able to move, not wanting to move, feeling depressed, feeling self-conscious about maybe going to the gym or exercising outdoor, to then now moving that to a positive cycle of losing weight and feeling better about themselves. And that in and of itself motivates them to do more and more. So that there are significant changes post-operatively to people's lifestyles, and that will be absolutely required. Another important point that I discuss with patients is that in the first 6 months post-operatively, they're going to notice significant weight loss regardless of what they do. And that sometimes makes people complacent. The hormonal changes that we talked about related to the different types of surgery are at the peak in the first 6 months, and then they begin to wane off in the second 6 months. And by around 12 months, really, they have blunted off, and weight loss plateaus at that point. What really maintains weight loss or results in further weight loss beyond that is very much about the lifestyle choices that people make. So that's why it's important to institute those lifestyle choices or those positive behaviors in the first few months after surgery, so that when you come to 12 months' time, you're not then faced with another battle. And that battle can be a big challenge if you've not already tried to make those changes in the first place. This is not about finding some kind of silver bullet that solves people's problems. Surgery is a tool. We can't stress that enough. It is an extremely powerful tool. It's the most powerful tool that we have at our disposal. It achieves weight loss like no other treatment or intervention, including diet and exercise. But it is a tool. It needs to be used hand in hand with everything else, lifestyle modification, eating behaviors need to change. We need to look at some of the other contributory factors that may have resulted in weight gain in the first place. And I cannot stress that enough. So whilst this is not about removing accountability or responsibility on an individual basis, but in fact, this is more about giving people their responsibility or the ability to be more responsible by helping them lose weight.
Okay, and can you give us an idea of how effective the whole treatment plan is and what factors may influence success rates?
When we talk about success, we need to be very clear about what we mean by success and how we define success. For a lot of people, it is about losing weight and that's it. But for a large proportion of people that I meet and that I speak to, it's not actually about losing weight per se, but it's about changing or improving the impacts that the weight has. If you have type 2 diabetes, people want to have the ability to come off their medication or reverse that. We know for bariatric surgery, in some cases, in the bypass, for example, can result in 70 to 80% of cases of diabetes can be improved or completely reversed. With high blood pressure, similar levels of reversal or improvement can be seen. And so some people come to speak to me and speak to my colleagues, that is their definition of success. And that's why right at the beginning, we need to understand from the person that sat in front of you, what is success to you? If we talk about weight loss, then we've talked already about how powerful a tool it can be. We use this term excess weight or excess weight loss. Excess weight loss is any weight above a body mass index of 25, which is lost. Okay, so if you get to body mass index of 25, we would kind of term that as a healthy weight. The more invasive the procedure, the more weight you're going to lose. And so you probably lose more weight with the bypass compared to the sleeve, although there's not that much difference based on our data between those two options, but certainly far more weight loss than you would expect with the band, the balloon, and medical weight management as well. In terms of long-term success, well, we've already talked about the importance of addressing those contributory factors and those lifestyle choices that need to be modified. But if we look at the broad results, if you look at 10 people who have had bariatric surgery, 7 of those people will lose weight and keep that weight off. 2 people will lose weight and will regain some of that weight. And then 1 in 10 people will lose all of the weight that they need to lose, or maybe not lose as much weight as they needed to lose, but regain that weight. And that's really important for people to understand. Again, I can't stress enough to you how important it is that bariatric surgery is not seen as some magic cure. It's a tool that has to go hand in hand with lifestyle modification and risk factor modification as well.
Okay. So thank you for those really clear, detailed answers to my questions. As you know, I ask patients and the public to submit questions beforehand in order to ask during my podcasts. Are you happy for me to ask you a few questions that have been submitted?
Absolutely.
Okay, great. So I must stress at this point that it's very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I've summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. Okay, so the first question from our listeners: why is it so challenging to get bariatric surgery on the NHS? Clinics make you lose weight first and then don't follow through with surgery. Why? That's not an incentive. You might as well stay obese.
So without doubt, the provision of bariatric surgery on the National Health Service is a politically volatile topic. And I think, I have my own personal views of how a bariatric surgery service should be run, and certainly my colleagues do. And we recognize that access to bariatric and metabolic or weight loss surgery is significantly limited. And to give you a depressing figure, a recent study undertaken in 2019 identified nearly 4 million people in the United Kingdom would fulfill the eligibility criteria for bariatric surgery, whilst on average we're performing 6,000 operations on the NHS every single year. And in fact, that number is reducing. The reasons why access is reduced, as I say, I think very much is a political reason. There needs to be political will to improve access. But in general, there needs to be political will to address the source of obesity in the first place. So it's no good just trying to sort out the symptoms, but we also have to find prevention in the longer term. On an individual basis, this person has my utmost empathy and the empathy of my colleagues. I want to reassure people that this limited access is not because of the healthcare professionals working within these services. We very much want to expand our services and want to increase access. And the reality is because access is so limited, people are therefore having to make difficult decisions, having to dig into life savings, take out loans to go to the independent sector where they may not be able to, have ideally afforded to, or even worse, go abroad for cheap surgery. And, that's a topic we've covered already. You get what you pay for, and cheap surgery, unfortunately, comes along with, complications and other issues that we've already discussed. So in summary, that this person has my utmost sympathy. The why is very much a political reason. I'm sure you could write to your MP, and that's what I advise people to do. Write to their representatives, asking them these questions. We have a highly effective treatment which can help people significantly, and yet it's not being accessed appropriately.
And it seems counterintuitive that patients are being told to lose weight before having weight loss surgery. And before you said that they don't require to lose weight before they have their surgery. So I don't know.
So there's
any comments on that?
Absolutely.
Part of the question.
There is no data which suggests that losing a specific amount of weight will result in success or failure post-operatively. The fact that you are considering weight loss surgery tells us already that you've struggled with your weight loss. It is bonkers, but I think it's almost like a screening exercise. We we work within the NHS, and the NHS does have finite resources, and sometimes, because of that, there needs some unpalatable decisions need to be made by politicians and people who hold the purse strings. As I said, we have our own ideas and we have our own opinions, but we don't make the decisions, unfortunately. But I want to reassure people again that there is no link between losing a significant amount of weight and the success or failure of surgery post-operatively.
Okay, thank you. The next question is, I suppose, maybe related. Why are GPs not referring patients for bariatric surgery?
Again, it's a complicated answer to a simple question. One thing that we have seen recently is an increase in referrals by GPs to the first step in the steps to weight loss surgeries, what we call tier 3 weight management. And for the simple reason is that they've been incentivized to do so. I have, having grown up and worked in this region all my life, I have a lot of GP friends, and we often discuss these topics. And they all say the same thing. They're incentivized. There's a big political push to increase referrals to tier 3 weight management. And that's really at the heart of it. When you look at the increased access to other health services, it's all down to incentivization. How do you make it attractive for GPs to refer patients? It's also down to perhaps education of our primary care colleagues. Whilst I personally seen a greater acceptance and a greater understanding by GPs to refer for tier 3 weight management, some of our colleagues may not necessarily be aware of the power or the effectiveness of these types of treatments. And you also have to understand that GPs are massively stretched. They have limited time to see patients. And having a difficult conversation about obesity and the different treatments available to patients can take a long time. Lots of patients who struggle with their weight find it difficult to talk about their weight. And so if you've got a 10-minute consultation to talk to somebody about something else, oh, and by the way, let's talk about your weight, that can be extremely challenging. So I certainly don't put the blame at the feet of our GP colleagues. They themselves are facing great challenges and stresses, and they need support and they need incentivization. But ultimately, we need more access and we need to expand services.
Indeed. And can you give us an idea of what happens at tier 3 weight management?
So there are 4 different tiers of strategies to address weight loss or to address obesity. Tier 1 is the universal preventative approaches, the promotion of healthy lifestyle choices, etc. Tier 2 is very much primary care treatment. So doctors may be able to prescribe certain medications, may be able to subsidize gym memberships, may be able to give simple advice, and may be able to refer to dietitians within their practice. Then tier 3 is really where we have a far more structured approach to weight management, where quite often you may see medical doctors with specialist interest in weight loss, who may be able to prescribe more advanced medications, certain injectable medications. There may be a psychologist involved in tier 3 weight management to address the underlying psychological impacts that mental health might have, or previous trauma may have contributed to weight gain. You will have dietitians, and again, you'll have a promotion of exercise and physical activity. It's really important to say that tier 3 weight management is not standardized. There's great variability even within our city in Greater Manchester. Different tier 3 weight management services provide different levels of care. And so this disparity in and of itself is an issue that needs addressing, but that's for another day. Beyond tier 3, once somebody has then completed their tier 3 weight management program, which typically takes anywhere from 6 to 12 months, but we know because of the COVID pandemic, etc., things are taking a lot longer. They can then be referred to what we call tier 4 weight management on the NHS, which in the Northwest is Salford Royal Hospital, which sits within the Northern Carolines Foundation Trust. And that's where patients are seen to be given education on weight loss surgery and talk to them about the different options available to them, talk to them about the risks and benefits of surgery. And then at that point, they will go on a waiting list. Unfortunately, that process of referral from the GP to tier 3 weight management, to tier 4 weight management, and then surgery can take up to 3 and even longer, 4 years sometimes. And so that is extremely frustrating for a lot of people. There are certain scenarios where patients who, as you've mentioned today, have urgent medical conditions such as endometrial cancer, just to give you an example, or have other conditions that need urgent care that can't be instituted or offered until they've lost weight. They can go on what we call a fast track or an expedited pathway, by having a direct referral into the surgical centre at Salford, and then we would discuss it within our multidisciplinary team.
Okay, thanks for that. Next question. Are women targeted as obese more than men?
So that question, I could read that in two different ways. I could read that, is there stigma against overweight or women who are overweight or who have obesity more so than men? Or I could read that as, are women being offered treatments for weight loss more so than men? Let me answer the second question first, or the second point first. Without a shadow of a doubt, the vast majority of people that come to see me, either in the NHS or in the independent sector, are women. I would say 90 to 95% of people having surgery for weight loss are women. And there is an underrepresentation of men, as well as other ethnic backgrounds, who may suffer more so with the ill effects of obesity and weight gain compared to Caucasian women. And so I would stress and I would advise men in particular to consider this as a tool, because it's men who have a higher risk of cardiovascular disease. It's men whose weight distribution tends to be central and around the midriff, which is a greater danger in many respects and increases their risk of developing diabetes, strokes, heart attacks, etc. And so there really needs to be a drive to increase the uptake or increase access for men and also people of ethnic minority backgrounds. As we've mentioned, South Asians are at a higher risk of type 2 diabetes, and their eligibility for weight loss surgery is lower than their Caucasian counterparts. So that's what I see, from that perspective. If you're talking about, are women stigmatized about their weight? As a man, I'm not quite sure how I'm going to be able to answer that question. But without a shadow of a doubt, again, social media and these idealistic representation of what a woman should be like, and what is achievable and what is quote unquote normal, is there for us to see. And that's why when I speak to men and women about weight loss surgery, look, we're not going to ignore the fact that if we lose weight, most of us feel better about ourselves, and our self-esteem or self-image may improve. But the focus is not about the scales per se, but it's about improving health, well-being, quality of life, and not just health in with respect to physical health, but also mental health as well.
Okay. The next question is, why have we turned into a nation of obese people? Is it since fructose was introduced by the Americans?
We've touched upon this already, that there are lots of contributory factors. Yeah, there's lots of contributory factors. And we've talked about the environmental and societal changes that we've seen over the last 40, 50 years. And certainly the questioner has already, asked a bit of a leading question, which is it because of our diet? Without a shadow of a doubt, diet plays a major, major role in why obesity has become more prevalent. When we look at other countries who are adopting what we term quote unquote Western diet, we see higher rates of obesity as a consequence. Fast foods, highly processed foods, processed carbohydrates, fructose included. So I have no doubt in my mind that has contributed to the problem. We've talked about pervasive advertising. We know that, to go extra large is only an extra 20, 30 pence,
Absolutely.
And so it's easier for people to take on more calories, eat the bad food, because it's easier to access. One of my favorite slides that I like to give when I give presentations is that the impact of or the density or the number of fast food outlets according to socioeconomic class or socioeconomic scale. We know people who live in lower or poorer communities have a higher density of fast food and takeaway outlets than people who live in, areas with big houses and big cars. So there are lots of factors that need to be taken into account. We're not here to take away personal responsibility or accountability on an individual basis. But as I said right at the beginning of today's discussion, we need to look beyond that. We need to look beyond the individual. We have to look at a societal issue as well.
Yeah, because it surrounds you constantly, doesn't it? It surrounds you. You go to the till at any big supermarket, surrounded by unhealthy food. Okay, the next question is, do you think bariatric surgery in the private sector in the UK is sufficiently supported and safe? You mentioned about big multidisciplinary teams, which are a common part of working in the NHS. Do you think this is reflected or reproduced adequately and safely in the private sector?
Short answer is yes, definitely. Bariatric surgery is well supported and in some circumstances can be offered at a higher level sometimes compared to some of the NHS practices. And that's because we have a little bit more autonomy and we are less constrained in terms of what we can offer and the care that can be offered. Generally speaking, NHS services are fantastic. They're well supported. But yes, we have within our multidisciplinary teams, we have dietitians, bariatric nurses, psychologists, physiotherapists, the surgical team, and then on the wards we have well-trained nurses, we have well-trained doctors in the hospitals, within theatres, we have teams who are dedicated to undertake bariatric operating lists. And the bottom line is if I felt in any way vulnerable or unable to provide the care that I want to provide for my patients, then I simply wouldn't be undertaking it here.
Okay. And the next question, and I know you gave us a beautiful description of all the surgical options, but as this listener has specifically asked about one, I'll ask it again. What's the scoop on endoscopic gastric sleeve? Seems to be a new thing, but not much seems to be out there about it.
Yeah, so we talked about that briefly. The endoscopic sleeve gastrectomy is a procedure which is done, it's a non-surgical procedure which is done using a camera or a gastroscope. The person is heavily sedated. It takes between 45 minutes to an hour, there or thereabouts, and involves us placing carefully placed stitches or sutures within the stomach in order to close off the stomach and make it a lot smaller. What we often are asked about is how does it compare in particular to the laparoscopic sleeve gastrectomy or the surgical sleeve gastrectomy? And because it's a relatively new procedure, we don't really have the long-term results yet. The expertise is certainly not there, not present in the UK compared to some regions around the world. And we don't really know about the hormonal changes that occur and whether they are as profound as you would see by physically removing part of the stomach. What we do know is that the weight loss achieved through the endoscopic sleeve gastrectomy by the admission of those who undertake this procedure is certainly less profound than with the laparoscopic sleeve gastrectomy. And therefore, I would consider this a completely different procedure. This is not something that should be compared or should be seen or discussed in the same light as a laparoscopic sleeve gastrectomy. It may take some of the principles of the laparoscopic sleeve gastrectomy, but it's not the same operation. The outcomes are different. And because it's a new operation, we don't know what the longer term implications are going to be, not just to weight loss, but also in terms of weight regain, and also due to complications. We don't really know what the complication profile will be in the very long term for patients.
Okay, thank you. And our next question, I've been referred for bariatric surgery due to endometrial hyperplasia, which we mentioned before surgery. How long after the bariatric procedure will I need to wait before I can have a hysterectomy?
So this very much depends on the surgeon themselves, the gynecologist who's undertaking your surgery. So you'll have to discuss that with them. It all very much depends on what your start weight is as well. The higher your start weight is, the more weight you'll have to lose in order for your gynecologist to be able to safely undertake your surgery. Most people at a guide should be aiming anywhere less than a body mass index of less than 35, ideally less than 30. But in a lot of cases, that's neither realistic nor is it appropriate, because if you are, we've talked about the fact that surgery can take weight loss from bariatric surgery can take up to a year to achieve the full weight loss that is possible. And for a lot of people, they can't wait a year. So it's about balancing up the risks and benefits, as we would do with any intervention or treatment. But you'll need to speak to your gynecologist about that.
Okay. And next question, can you be too obese for bariatric surgery?
So I've never come across a patient who has ever been too obese. And what I want to stress to you here is that doesn't necessarily mean that the first step is surgery. And that is really the importance, again, of a multidisciplinary team approach. Quite often, I'm referred patients on the NHS in particular, or even in the independent sector, whose body mass indexes are greater than 60, 70, and even very, very rarely greater than 80. And what we would do is we would address, again, the underlying contributory factors. Without a shadow of a doubt, the higher the body mass index, the greater the risk at the time of surgery. And ideally, I would want for somebody's body mass index really to get around the 60 mark before we are considering surgery. So certain strategies may be to get the patient to have some medical weight management in the first instance. They may be offered certain injectable medications alongside strict dietetic support. We may even suggest that a patient is offered a gastric balloon in order to reduce their weight in the first instance. When their body mass index gets closer to the 60 mark, then at that point, it is probably quite safe to undertake a sleeve gastrectomy. But again, it's all about expectation. No single procedure for somebody who has a body mass index of 60 is going to result in such weight loss that their BMI then falls to 25. It's just not physically possible. So what we might do then is offer a multi-stage surgical approach where we start off with a sleeve gastrectomy, and then if there is a need or a requirement later down the line, 18 or 24 months down the line, they may be offered a conversion from a sleeve gastrectomy to a gastric bypass to give them that additional weight loss further down the line.
Oh, that's really interesting. Didn't realize you can have different procedures in succession. So again, individualized care, right? We keep saying. Okay, so this is an interesting question. If you had a magic wand, what would be the ideal team for successful weight loss in very obese patients who are medically unfit? So you've spoken about it before, but This is it.
So I'm very lucky in that I work within ideal teams already. We already have that set up. So I don't have to imagine what an ideal team would look like. we're very lucky to be able to offer those types of services and procedures, not just within the NHS, but also within the independent sector. And we've taken a lot of time and effort to develop not just the team members and choose them and train them individually, and ourselves. We are always undergoing training and education and continuous professional development, but also bringing on board and adopting new treatments and new interventions all the time. So your magic wand, well, I said I don't need that. But again, I'll discuss and I'll describe what a multidisciplinary team looks like. One that includes not only the surgeon and the medical weight management doctors, but also one that includes a psychologist, a bariatric nurse, a physiotherapist. Who else? Have I mentioned psychologist already? I think I have. And then the wider team who are experienced not just within the hospital, but also in the outpatients department. Little things such as accommodating people who struggle with their weight in the outpatient department makes a big difference, such as having the right chairs, such as having a waiting area which is, can accommodate people who struggle with their weight. All of these little things, in a step-by-step approach, have allowed us to arrive at a situation where we can offer an ideal service both in the NHS and in the independent sector as well.
Perfect. That's wonderful. Last question from our listeners. How do you think the role of the GP can be extended to manage obesity?
So that's another great question. And what I probably do is refer to the management of other medical conditions that we've seen historically. If you cast your mind back to when atherosclerosis and cardiovascular disease was managed, in the initial stages, it was very much managed by specialists in the hospital. Something as simple as a statin, which is handed out by GPs and prescribed very, very easily. Initially, that needed to be prescribed by a specialist in a secondary care facility in a hospital. And what I think will happen in future, as an important part of this wider strategy that we've talked about, is that a lot of the weight management services will need to be developed or will need to be delivered within primary care. And that means those multidisciplinary teams will need to be set up in primary care facilities. That means the introduction of psychologists and nutrition or dietitians, but also the ability of GPs with specialist interest in weight management to then be able to prescribe and give out some of these new medical interventions, such as injectable treatments. Some of these are already available online and without adequate supervision, and that's what it all comes down to: proper supervision of these what we call GLP-1 agonists, such as semaglutide and liraglutides, also known by their trade names as Saxenda and Ozempic and those types of medications. So I very much see a trickle-down effect whereby the treatments that we offer in Tier 3 weight management will need to then be introduced in primary care.
Yeah, indeed. Okay, so that's it for our listeners' questions. I've got one more question from myself, if you will indulge me. So, Bilal, you have managed many patients with weight problems in your career thus far. Given the opportunity, is there anything that you'd like to say to patients who are having issues with their weight?
Without a doubt, obesity is a medical condition. And our understanding of obesity has changed over the last 5 to 10 years. It's complex, it's chronic, it's relapsing. We understand that it impacts on every aspect on most people's lives who struggle with their weight. We've talked about the fact that weight impacts on people, from a physical perspective, reducing their ability to move, reducing their ability to enjoy life. We know that patients or people who struggle with their weight are stigmatized, face discrimination. People who struggle with their weight don't need to be told that they're overweight. They know that they struggle with their weight. They know that they have a problem. And instead of criticizing and stigmatizing, we need to be helping and we need to be empathetic. My main message to people who struggle with their weight is that there is help out there. Help out there from people who care, people who are empathetic, people who understand, and that is key. Some of these treatments are profoundly powerful. They offer long-term and sustainable weight loss, and they are extremely safe. We are never complacent about the fact that these surgeries do come with some very small risks of complications, but by and large, they are largely safe, and the positive impacts that they have on patients are profound. The biggest regret that people have who have had bariatric surgery is very clear, and this theme comes time and time again. The biggest regret that people often state to me is that they wished that they had done it sooner. And I don't want you to rely on what I'm saying here today, but go online, go onto social media, follow some accounts or see what people are saying who have the lived experience of bariatric surgery, and see what they have to say. And if you want to consider this as an option and you want to discuss matters further, then we are here to discuss it in an empathetic way and in an individualized and tailored approach as well.
Thank you. Thank you. So, in closing, Bilal, it just remains for me to say thank you. Thank you for sharing your vast wealth of knowledge with us today. Thank you for coming onto the podcast to be interviewed and for supporting my efforts at educating patients. But most of all, thank you for being the fantastic, empathetic, compassionate doctor that clearly you are, and for helping so many people who've had issues with their weight. Thank you so much.
And thank you for inviting me, Gail. And thank you for your efforts as well. You know, what you've got here and your podcast, I'm sure is just gonna go from strength to strength. In years to come, we'll look back and see our discussion that we've had this evening. And I'm sure I'll be surprised that I even made it onto this podcast, because you're going to be such a superstar in the future.
Oh, stop it. Thank you so much. Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.